Thank you, our beloved President, sir, and the chairpersons. Now, here, the experts are here. We have got two experts from across the Atlantic, Dr. Prakash Didawaniya and Dr. Sidney Smith. So we'll exchange our views in the keynote address. May I invite the chairpersons on stage, please, Dr. Monotosh Paja, Dr. Pradeep Dev, and Dr. Shivananda Datta. The talk time is 15 minutes with 5 minutes interaction time. If you like interaction, you keep the 5 minutes. If you do not like, you can eat up that 5 minutes. Thank you, sir.
A distinguished chairperson, ladies and gentlemen. Before I begin, I'd like to first of all thank the organizers, particularly Dr. Sumitra Ray, Sora Mukherjee, and Dr. Santanu Guha for inviting me to share my viewpoints about this particular topic. As you know, hypertension is an old disease. We all think we know what we are doing, but there is a lot of change that's going on. So this particular title selected by Sumitra was Any Hope for the Sprint? How long and will blood pressure management elude us? And I'd like to give you my perspective. First of all, I'd like to emphasize that as we know, even currently, despite all our efforts, hypertension remains the leading cause of death and disability in the world. This slide from the WHO data by Izati shows that both in developed and developing countries, hypertension is the top medical condition that we encounter as a leading cause of death. We have also shown from the study that was done just a few years ago within India, this is the India Heart Watch study of 6,400 consecutive individuals, unselected individuals at 11 metropolitan centers. We have shown that hypertension, as you can see, begins early in life, and you clearly can see even pre-hypertension is present in as many as 30% of the youngsters between 20 and 29 years of age. And clearly, as has been shown in the Western world, hypertension prevalence increases with aging of the population. And hypertension is clearly very important because it is one of the inciting factors for the subsequent target and organ damage. As you know, along with other risk factors which are often present in patients with hypertension, you have vascular dysfunction, endothelial dysfunction, setting in the vascular disease, risk of myocardial infarction, and of course downhill path to heart failure, the end stage of the cardiovascular disease. Many studies, and one example is here, have shown that when you look at the 4 leading cardiovascular disorders, for example, MI, coronary heart disease, 70% of the people have blood pressure that is in the range of 140 or 90 or above, or majority of the strokes, and almost all patients of heart failure have hypertension as the leading cause. It should be recognized that hypertension is the #1 population attributable risk factor for heart failure. And of course, it accounts for significant amount of cost and human suffering. Now, this is a simple slide, which I'm sure many of you have seen, but this is important to emphasize that although these data are very important, they have been misinterpreted by many people. These are observational data from the meta-analysis done by Sarah Lewington of more than 1 million people followed for 12 years. What this shows is, in the observation, progressive increases in blood pressure, both systolic and diastolic, is starting at the level of 115/75, and then 20 and 10 millimeter increase in stepwise. There is doubling of the cardiovascular mortality. However, what these data do not show and have been misinterpreted is that lowering blood pressure in this manner will lower the cardiovascular mortality proportionately. And this has been the main cause of the very topic of my discussion. You cannot equate observational data to what we are going to do to the patient. There are a lot of differences for that. And of course, we know that treatment of hypertension is beneficial. We have seen significant benefit. This, for example, in this meta-analysis, reduction in blood pressure reduces risk of stroke, cardiovascular events, and CHD death. But the major discussion point today is what are the appropriate blood pressure targets in different patient population, and which is the most appropriate choice of drug. We have more than 160 molecules that are currently utilized for treatment of hypertension patients. So let me first of all visit with you what was then and what is now. So JNC 7 guidelines, and JNC 8, by the way, is not a established guideline. It's an expert panel. We'll talk about that in a minute. But I want to emphasize that here you can see general uncomplicated hypertension. The recommended goal was less than 140/90. For diabetes patient, less than 130/80, which was not based on any properly done randomized trial. When the trials were done, as you are well aware, we know that we should not reduce the blood pressure that much, and I'll come back to that later. And CKD, we still think, despite lack of many good trials, the target blood pressure should be less than 130/80. The AHA recommendations are listed there. They are very similar. These are the new guidelines. These are the guidelines from entire world that are summarized for you on this table. And you can see here in general, most of the guidelines recommend target blood pressure of less than 140/90. However, the JNC 8 expert panel recommended that in people who are elderly, above 60 years of age, perhaps we should not lower the blood pressure as much. And there was dissenting opinion within that group. We can talk about that later on. And also in China, they were very cautious, particularly in people over 65 years of age. Now let me explain the reason why the JNC 8 expert panel recommended this goal. This was because of the lack of any randomized controlled trial. That group was assigned to only use randomized controlled clinical trial data to come up with their recommendations. It is not because they don't believe in this, and this is why 5 of the expert panel members came out with a dissenting opinion. Diabetes, you can see now, if most groups are recommending less than 140/80 because of the ACCORD, ADVANCE, and VADT trial. The molecule really doesn't matter. As you can see, the major guidelines, JNC 8 on the top, and the European Society in the bottom, they recommend that you could use diuretics, you could use a RAS blocking agent, ACE inhibitor or ARB, or CCB as needed. But the main point I'm going to discuss is, should elderly patients with a systolic blood pressure between 140 and 160 be given antihypertensive drug treatment or not? And if they are to be given treatment, what should be the goal blood pressure? How low should we go? And one point I want to emphasize is, and this is particularly important for the audience here, current evidence largely examines these data in Caucasian populations. These data may not be easily transposable to the Asian and black populations. So the major study that shook everyone up was the SPRINT trial. The main objective of SPRINT trial was to examine the effect of more intensive versus less intensive blood pressure control with whatever it took. The intensive arm target blood pressure was less than 120. The standard arm was a standard guideline recommendation of less than 140. And this particular trial was prematurely terminated by NIH, having defined that it has reached its endpoint and it will not be safe to continue the trial in a randomized blinded fashion. So the primary outcome of SPRINT trial was composite of occurrence first event of myocardial infarction, ACS, non-MI ACS, stroke, acute decompensated heart failure, and cardiovascular disease death. Keep this in mind as I show you the endpoint later on. Major endpoint was stroke, myocardial infarction, ACS. Heart failure was one of the endpoints, but as you will see, interestingly, not all the endpoints met the target. So here are the data. The baseline data, you can see clearly, show that this was a desirable group where we need the answer. The mean age was about 68 years. Many elderly people, about 28% were elderly, above 75 years of age. Good representation of women. As I said, mostly white Americans. African American also accounted for a decent 30%. Hispanic were minor representation. But keep in mind, as we review the results of other trials, most of these patients, majority of them had either high Framingham risk score, and 20% had prior evidence of cardiovascular disease. Majority of them were taking antihypertensive drug, 91%, and most of them were on dual antiplatelet therapy. Now also notice, systolic blood pressure in these people at the beginning was already well controlled. Mean was less than 140. For the entire group, 139.7. For the two groups, very similar as well. What was their renal functions or other important thing? You can see that their mean GFR was normal. However, there were some people who had decreased GFR. In other words, CKD, they were about 28%, and cholesterol and lipid values are shown here. So, very important point to keep in mind, because this is not listed in the paper if you read just on the surface. It's only in the supplementary table. The blood pressure was monitored in the sprint trial in a very unique fashion. It was monitored by an automated blood pressure machine in the office where a patient was put in a quiet room, told the machine will take the blood pressure, and then the attendant walked out. So-called unattended blood pressure for 3 consecutive readings. Antihypertensive medication were given to reach the target, and periodic assessment of orthostatic hypotension and related symptoms were measured. And what you can see here is clearly what they went to achieve. The intensive arm, they were able to achieve blood pressure very close to where they wanted, 121, whereas the standard arm, there was not that much reduction, further reduction, 136.2. Now, very important to keep in mind, how were they able to maintain the standard arm blood pressure at about the same level almost as the people entered? In many patients, they withdrew the diuretic so that they would not have further reduction in blood pressure. Keep that in mind as we review the results of the sprint trial. Whereas in the intensive arm, they had to add diuretic in many of the patients, and that probably is one of the main reasons why they found what they found. And they actually showed in the primary outcome that there was significant benefit in the primary composite endpoint in favor of intensive arm that was seen at about 1.5 years, and you can see wide separation. Now let's examine what happened in the different components of the primary endpoint. You can see here myocardial infarction, no significant difference. Non-acute MI, but ACS, no significant difference. Stroke, no significant difference. Have you ever seen a study of antihypertensive drugs where there has been no reduction in stroke? At least I haven't. If anybody has seen during the discussion period, I'd like to hear about it. And the major endpoint that really was benefited was heart failure. Now remember what I told you. They withdrew diuretics in the standard arm, thereby unmasking heart failure that must have been controlled with diuretics on board. And they added diuretic in the intensive arm, thereby masking heart failure because they were already given the diuretic therapy. Very important to keep in mind. And that predominantly accounted for the overall difference in cardiovascular death as well. So here is the all-cause mortality that was also decreased, but we all know that patients with heart failure will have increased all-cause mortality. So that probably is what accounted for that. In addition to that, this beneficial effect whatsoever that might be was at an expense. You can see hypertensive episode occurred far more frequently, syncope episode occurred far more frequently, electrolyte abnormalities occurred far more frequently, and most importantly, the acute kidney injury was seen much more frequently as compared to standard arm people. How about the other trial? Earlier in this year, there were results of HOPE-3 trial that came out. And it's particularly important because HOPE-3 showed totally divergent result. It did not show any beneficial effect. It actually showed that in the group as a whole, there was no benefit. And this is particularly important, keeping in mind the HOPE-3 was a larger study, but it enrolled low-risk patients. So what we see in HOPE-3, and I don't have the pointer, doesn't work there, but what they showed was the benefit for the statin treatment arm, but no benefit for the blood pressure lowering arm. And what they then subsequently showed was, if the blood pressure is already low in low-risk patient, treating it further doesn't do any good. As you can see in the tercile group, the only group that benefited was the one at the lowest level, where the baseline blood pressure was 143 mean, and you can see that they had about 24% reduction. So the conclusion of the HOPE-3 group, which also is the largest study, came out earlier this year, was the fixed dose combination of candesartan thiazide diuretic by 6 and 3 millimeter, but did not reduce cardiovascular event. CV events were significantly reduced only in the highest tercile group, that is where systolic blood pressure was 143.5. Results were neutral in the middle third and trended towards harm in lower third. Keep that in mind. I'll talk about that just in a minute. Treatment increased the lightheadedness, but not syncope or renal dysfunction. Now, just for your information, comparison of the two trials, very important. And I just put this table together last night, so it's not as cosmetically good as the other slides. But very important to see, the mean age in the group was comparable, and the distribution of the patients, of course, is somewhat comparable, but there were 29% Chinese individuals, more Asian representation in the HOPE-3 because it was done in 21 countries. Very important to keep in mind HOPE-3. There was no patient with CKD, they were excluded. There was no patient with cardiovascular disease, they were excluded. And their cardiovascular risk was very low as evaluated by the Framingham risk score. There was run-in period in HOPE-3, but there was none in the sprint trial. And of course, we can see that the overall number of medication used was higher in the sprint trial. And of course, you know the results that I just shared with you. Now let me give you a word of caution. What should we then do? You can see here, these are the results from the ESC meeting of the clarified registry. This was a registry of patients with coronary artery disease, 23,000 patients, and there is still, if you call J or U-shaped curve, that somewhere along the 130 millimeter blood pressure is the nadir for systolic and about 70, 72 millimeter for diastolic blood pressure. And what they showed was that if you look at this distribution in the forest plot, that people at the higher end of blood pressure, 140 and greater, have higher risk, but people at the lower end, also at less than 120, also have high risk. So let us not do any harm. So my take-home messages in this last minute is that findings of a sprint are difficult to generalize in clinical practice due to a number of reasons, particularly the methodology used to measure the blood pressure, because in general, blood pressure as they measured is at least 10 to 15 millimeter lower than what we do in office practice. The results of HOPE-3 also provides valuable insight in showing that the low-risk patients do not require aggressive blood pressure measurement. It probably can do some harm. And particularly important to keep in mind in general, hypertension is a complex clinical syndrome. We just measure the blood pressure values, but every patient is unique. We are dealing with heterogeneous group of patients with multiple comorbidities or not, and a strategy of one size fits all does not work in hypertension, even though it's a very, very common illness. And the target of blood pressure and choice of antihypertensive drug should be based on cardiovascular risk, associated condition, age, ethnicity, as well as careful consideration between balance between the benefit versus risk of various therapeutic strategies. So, Mr. Chairman, ladies and gentlemen, sprint had hope for a goal but missed the field. Thank you very much for your attention.
Thank you.
I'll be happy to take any question. That's why I wanted to rush through the slides, so we have time for discussion.
Thank you, Dr. Didwania, for excellent deliberation. But I'll like to make a very simple question. What did you learn from sprint and hope?
Well, I learned from a sprint that to do the trial, you have to do it like in the clinical setting. You can't use drugs and withdraw drugs from one group, particularly the heart failure endpoint. So the trial really does not deliver what it was supposed to deliver. The hope, on the other hand, shows that clearly patients who are at low risk and have blood pressure that is less than 140, we should not be treating because we can do harm. So I think quite often clinicians tend to treat hypertension as reflex, just treat everybody, and that's probably not appropriate, and we confirm that in the clarified registry, as well as what has been shown previously in the INVEST and other trials, that treating blood pressure too much could be of some harm. I think Sprint did provide very good service, and that is in elderly patients. There's a secondary paper of a Sprint that came out in the elderly patient. It showed that in elderly patients, still the blood pressure can be reduced safely, somewhere about 130. We don't know exactly. They didn't divide the groups into various terciles, which I like to see the data, but they did show that you can lower the blood pressure. When you can do it safely, it could be helpful.
So any question? Yes.
May I have one question, sir? Now we are using more and more of ambulatory blood pressure monitoring and putting it into the clinical decision making. How will you really fit those data with this kind of trials and to treat your patients?
No, I think that's a very important question, Sumitra. I think more and more, although we don't talk about it because it's not feasible in general population, more and more data suggests that blood pressure variability, which can be easily measured by ambulatory blood pressure, but also can be done by repeated monitoring at home blood pressure monitoring, is a powerful predictor, much more powerful predictor than blood pressure at one point in time. And I think that's very helpful. Also, it helps us diagnose both the masked hypertension and also patients who have white coat hypertension. That can only be done if you do ambulatory blood pressure. And certainly, a lot of data that have come out in the last 5 years have shown that morning increase in blood pressure, so-called the morning surge, could be highly predictive of increased risk of stroke and myocardial infarction.
Yes,
Yes. Thank you for your excellent presentation. My question is, it's a practical problem. A 70-year-old man comes with a blood pressure of 180 by 90, and you'd start treating it, and after 3 months, the blood pressure is now 150 by 60. So what would be your choice of drugs? And the obvious problem, the dilemma faced is that if you lower the systolic blood pressure further, the diastolic reaches a point where it comes in the region of harm. So how do you deal with problems like this?
Very good and very common clinical scenario. First of all, I think in elderly patients we should keep in mind, when you gave a different patient example, but where you're talking about the issue is patients with what we call isolated systolic hypertension, but your patient had diastolic up as well, so that's a little different. But in those particularly there is concern, as you reduce systolic, you want to be cautious not to reduce diastolic too much. Good news is the diastolic in those patients does not go down too much. Their diastolic is not a true reflection of diastolic blood pressure. It's a reflection of diseased arteries. So diastolic is fixed. It does not go down or whatever. But always, as I said, it's a heterogeneous group of patients. You need to look at individual patient. If your patient had prior stroke or had TIA, has carotid vascular disease, has renal disease, then of course I would not be too aggressive. I would carefully watch for any signs or symptoms of hypertensive risk.
Sir, Hope 3 is against the concept of primary prevention by polypill. Do you agree with it?
Well, they are not against the primary prevention. What they are saying is you should not treat blood pressure unless it's in abnormal range. Nobody has ever recommended treating blood pressure below 140. So I think they just echo what has been already there. It's common sense. But it took a large study to really show it, because there is a lot of move in treating everybody and assuming that treating blood pressure at any level would be safe. And I think this is largely because the misconception from Sarah Lewington data, which has been misconstrued, and observational study should not make a reasoning for intervention.
Okay, thank you very much, Dr. Didwani. Thank you for an excellent deliberation. Thank you.
Thank you.
May I now request Dr. Sidney Smith to come to the dais and give his deliberation on an excellent subject, a new subject, air pollution as a cause for CVD. Yes. Yes. It is just a formality.
Well, thank you very much. I'm very honored to be here, and especially in Calcutta. It's my first visit. There's so many great things about India, and especially Calcutta. 3 Nobel laureates, fantastic football, and one of the oldest medical colleges in Asia. So it's really honored to be here. And I also, as I flew in, heard about the whole issue of air pollution, which is an area that I've been interested in for the past 15 years, as to whether or not this is a significant risk factor. So I'm going to talk a little bit about air pollution as a cause for cardiovascular disease, and whether or not it is actually contributing to cardiovascular death. Now I have three different pictures here. This is Los Angeles, around 1975. I actually had to drive through Los Angeles to get to San Diego. I was moving from Colorado, where I was heading the cardiac cath lab, to San Diego, where I had a new job in cardiology, and this is the bad smog and pollution in Los Angeles. I show you this picture because we don't have that kind of pollution as much anymore, so I know that pollution can be fixed. I'm confident that the problems in India with pollution, in China, can also be fixed, because we had the same problems in the United States. These are plants south of San Diego that are spewing pollution up into the air, and this was one of the causes for the pollution in Southern California. And then over here, this is Delhi. This is people eating dinner in Delhi. And I show you this to remind you and remind us that 50% of the world actually cooks indoors in developing countries. And so this microparticulate matter is a big issue there. Now here it is, Calcutta. And this is in 2008 or so. It was Diwali, which is a problem because of the burning. And they actually had to shut down the airport, and it was pretty severe situation. The microparticulate matter measured, the 2.5 was 461. So remember that. This is Diwali, and then only yesterday, this is Delhi, where particulate matter reached 600. So you can see that it's a bad situation. Again, this is Diwali, and as they pointed out in the newspaper article, sustained exposure to the concentration of PM 2.5 of 600 is equivalent to smoking 40 cigarettes per day. So it's a really severe issue, this air pollution. Now it's not just India or Los Angeles. This is Chile. Chile, I go down there frequently. You can see the earthquake in 2009, and then another earthquake in 2013 here. These are the ashes. This is the smog that you see in Santiago in the winter. Again, it's a bowl like Los Angeles with mountains around it, and you get thermal inversion. So it's a problem in Chile. It's not new. The first point I wanted to make is that it's all over the planet. It's not just in one country. The second point is it's been with us for a while. This is King Edward. This is back in 1200. King Edward banned the burning of sea coal and actually threatened to cut off the head of anybody that was found burning sea coal. So ISIS has nothing on King Edward. I mean, he was doing this years ago. Now London, again, and this is 1661. London's inhabitants breathe nothing but an impure and thick mist accompanied by a fuliginous. Fuliginous comes from the Latin fuligio, which means soot. Fuliginous and filthy vapor corrupting the lungs. So they had this in London back in the 1600s. And you remember Monet, his paintings of London actually showed this kind of misty area. And then finally, London became known for the pea soup, fog. And in fact, the word smog comes from the combination of smoke and fog. Smog. In China, they call it umei. It's a combination of smoke and fog. So in Mandarin, they have the same approach to smog as we do in English. Now, more recently, there have been major issues in Donora, Pennsylvania, 20 people dead out of 14,000 living there. In London, the killer fog, which was a major issue, 4,000 people. This is 1952 in London. 4,000 people were dead after the killer fog. And then this led to a remarkable action, and that is the Clean Air Act in the UK, which actually was enacted by 1956, after the 1952. And you can see here the significant reduction in air pollutants which has occurred as a result of the Clean Air Act. So, and I know, I read in the paper this morning that in Delhi, that they are taking action now to try to address in Diwali the burning, to look at some of the industrial pollution. So this is an area where a governmental action, I think, coupled with societies, like the Cardiological Society of India, if you have a dialogue with the government, begin to look for a way to move through this. But you can see that the action that they took in the UK had a significant effect and benefit for the population. Now this is the worst that I've seen it. I actually have 4 apps on my phone that tell me air pollution all around the world. I have one that we can tell you exactly what it is in Calcutta, Bangalore, Mumbai. I can take you all over India today, and we can look at the PM 2.5 right on my phone. Tell you what it is in Beijing, Harbin, San Francisco, wherever you want to go. The worst that I've seen it is 900, and I was in Beijing at the time. This is the Forbidden City. You can hardly, there's Mao, Chairman Mao back there. You can hardly see it. This is the one time that I actually wore a face mask while I was walking around in Beijing. If you look at the issue of air pollution, if you take, this is indoor urban air pollution plus indoor smoke. You got urban air pollution, which is largely increasing motor vehicles, impure plants. And you got indoor smoke and tobacco. If you take the 3 air pollution, what we breathe, it's going to give you a risk factor which is total, right up there with high blood pressure. So I think that we really do need to pay attention to the environment. The American Heart Association has come up with 2 scientific statements. This is the first one that I had the honor to serve on in 2004, and then a more important one which came out in 2010. And you should have a copy of that. I sent that in so you can look through it. And it deals particularly with particulate matter and air pollution. The 2 important things about this statement are that we said, number 1, it's a risk factor for cardiovascular disease. So people exposed to microparticulate matter develop atherosclerosis at an accelerated way that's not seen in people who don't have similar exposure. Number 1, it is a risk factor. Number 2, it triggers events. So if you take people with underlying atherosclerotic vascular disease and expose them to microparticulate matter, to pollution, you will see more admissions with acute coronary syndrome, more stroke, more heart failure. It can trigger cardiovascular events. Those are the 2 important conclusions. So when we talk about air pollution, there are the nitrogen oxides, carbon monoxide, sulfur dioxide. These are major contributors to health. Secondhand smoke. What we're going to talk about a little bit more is particulate matter, PM 2.5 that we just saw in Delhi. Where what was it, 1,800 schools were closed because of this. Now, if you look at what are the causes for the particulate matter, motor vehicle emissions, tire fragmentation, suspended road dust. Particularly in Africa, suspended road dust is an issue. North Africa, power generation, industrial combustion, smelting, wind-blown soil, forest fires. So this is a little bit of what's going on with Diwali, the burning, but also if you go to Singapore, many of you have probably been to Singapore, you know that when they burn those trees in Indonesia, you get a lot of air pollution in Singapore. And if you talk to people who live in Singapore, they are very unhappy with what's going on in Indonesia because it blows right into their city. And then volcanic emissions, a good example of that were the two volcanoes that I showed you in Chile. So taking a look then at what we've got the plants that I talked to you about, we've got mobile sources, we've got the exposure to passive smoke, we have carbon monoxide, we have the development of fine particles, this is PM 2.5 and ultrafine, which are really quite small, and then we have the gases. All of these contribute to increasing oxidative stress and inflammatory response, autonomic dysfunction, arrhythmias, and adrenergic activation. So the major mechanisms that we see are endothelial dysfunction, platelet activation, the development of atherosclerotic plaques, and in situations where fixed obstruction exists, negative oxygen balance. Secondhand smoke very quickly, 1992, a major time in the United States. Secondhand smoke was an issue from the Surgeon General's report. There's a 25% increase in the risk of heart disease if you happen to be married to somebody that smokes. Forget smoking yourself. If you're around somebody else that's smoking, you've got a 25% risk. It increases both chronic and acute events. It's a risk factor for stroke. And all over the world, we've seen a reduction in acute admissions when secondhand smoking is enacted. This is a chart that shows you the summary. Down at the bottom is the summary of a meta-analysis. It's roughly a 17% reduction in events which occurs when smoke-free policies are enacted. Most recently in Montevideo, Uruguay, where Uruguay had a nationwide enactment of secondhand smoke restrictions. So tobacco control is a major issue for developing countries. Look at the two curves here. You can see the upper curve is in the medium and low income countries where the tobacco use is just going up and up and up. High income countries are beginning to restrict it. The tobacco companies are basically raping the low and middle income countries. They're coming in, they're selling their products, they're not restricted, and we're seeing an increase in cardiovascular disease. Not fair. Talking a little bit about particulate matter, these are the gases that you see. Here's human hair, for example. The PM, the coarse fraction, 10 to 2.5. This is the bad actor. The 2.5 that we talked about in Delhi, which was up at 600, comes mainly from combustion sources, distributed regionally. You can see this is the number of particles on the top of one hair. And then we have the ultrafine, which have roughly 4 particles per one of 2.5. And they contribute, they can go directly into the bloodstream. The 2.5 particles actually act at the interface in the alveoli. So there are studies, long-term health studies. Harvard and American Cancer Society both showed an increase in cardiovascular deaths. So it's not just lung disease. In fact, more cardiovascular deaths are attributable to air pollution than pulmonary. Sulfates and the microparticulate PM 2.5, 6% increase in cardiopulmonary deaths here associated with PM 2.5 from cancer, and then short-term studies showing that for each 10 micrograms per cubic meter of PM 10 increases in daily mortality. There are populations that are known to be at risk: the elderly, lower socioeconomic status. Patients with diabetes are more susceptible, probably because they have more diffuse vascular disease, and those with known underlying cardiac or COPD. There have also been some environmental issues with congenital heart disease in Eastern Europe and Los Angeles. So short-term elevations lead to admissions. Long-term exposure leads to the development of disease. This is just a graph showing the cardiovascular mortality associated with heart disease, short-term exposure, and then long-term. And then the mechanisms I talked about: pro-inflammatory, the autonomic system, and direct transmission of the ultrafine particles in the bloodstream. This is a schema showing you the oxidative stress, the increase in the beta IL-6, TNF-alpha, the autonomic, and then direct bloodstream. I want to show you this study, very interesting study. What they did was to take 20 patients who had known cardiovascular disease. These are people that had known cardiovascular disease. They then hooked up a Volvo diesel engine and piped the exhaust into the treadmill lab. They exercised them with the engine running, so they were exercising with the exhaust fumes going into the lab, and then they exercised them in pure air. And this is what they saw. A significant increase in the ST depression, the magnitude of ST depression, and also tissue plasminogen activator affected. So initially I thought this is unbelievable that they could do a study like this, pumping a diesel engine into a treadmill lab, but every day, you know, I see patients that want to know, is it safe for me to exercise outside? What do we really know about advising our patients? And it's quite clear it's a major issue. In the animal models, we can look at ApoE deficient mice that are on high-fat chow and show it affects their constriction to phenylephrine and also response to acetylcholine. So we know the endothelial effects exist in an animal model. We can see increases in plaque area in these ApoE deficient mice that have increased exposure to PM 2.5. We know that the carbon fragments are particularly important. The organic carbon is much higher in the ultrafine particles than the fine, the 2.5, so there's increasing interest in ultrafine particles. And again, one can show comparing the uptake in the presence of 2.5, much greater plaque deposition at various areas. So in summary, air pollution increases the short and long-term risk of cardiovascular disease. There are significant deaths around the world. We need more stringent standards. And I'm not a politically active person, but I think this is where we in cardiology need to communicate with our legislative bodies and get something done. There are groups that are known to be more affected by it. We know the acute triggering as well as the chronic relationship, and it's a modifiable risk factor. We need to start thinking about it. You can get on your phone information like this. You can go online and get it. I have it on my phone. This is the phone that I have for China. Interestingly, in Beijing, they were measuring particulate matter. This is what the government was measuring, and this is what the United States Embassy was measuring at the same time. The Chinese have made the United States Embassy take down. They can't monitor anymore. So you only get what the government tells them there. So here are some areas for future research. We need to know more about the basic mechanisms, and we need to understand the pathways. I'm especially interested in whether medications, for instance, patients that might be taking statins, if an enhanced inflammatory activity is somehow related to this, do patients that are on statins have less acute events when exposed to the increased particulate matter than those not? And then finally, conclude with this slide. You know Julia Roberts and Hillary Clinton, they have gotten together to develop stoves that are now being used in developing countries which are solar energy related, so that the groups that used to be sitting around with the burning fires are no longer exposed to air pollution. So there are ways that we can move along this and beyond it, and I do think it's an area that we need to think about. And I want to thank the society, for asking me to speak on this, because this is not really what you would call a mainline talk. I'll talk about dual antiplatelet therapy tomorrow, and I can talk about hypertension and lipids and all that stuff. But we need to pay attention to this issue of air pollution. Thank you very much.
Thank you, Dr. Smith. I believe the alarming incidence of coronary disease in India may be contributed to some extent by the air pollution prevalent in this part of the globe. And it was a very interesting topic, and I believe that reduction of particulate matter, reduction of nitrogen oxide, carbon monoxide, sulfur dioxide, etc., reduction of secondhand smoking. All these factors will be beneficial, and also diesel engine exhaust. And I may allow one or two questions from the floor if anybody is interested.
That was a very stimulating and interesting talk. I'd like you to comment on the differential toxicity of particulate matter versus gaseous emissions.
Yeah, I think that I heard part of what you said. Well, that you were more about the gaseous, like carbon monoxide, sulfur, and nitrous. Those are very important. But the studies that I showed you looking at particulate matter were analyzed and showed independent effect for them. The sulfur, the nitrates, and carbon monoxide really gets into the type of fuel that's being used for energy production and also in the engines that our cars are using. So I think the increased use of motor vehicles really accounts for a lot of the increase in gaseous emissions, and we need to find cleaner sources of energy. You know, at one point, I go to China a lot. At one point, the Chinese were talking about leapfrogging and becoming the leaders in the clean automotive car, you know, the Tesla type car, because they actually have a lot of the rare metals that are used in batteries, and they saw this as a way that they could become very dominant in terms of the economic aspects of energy. But it hasn't moved forward as quickly as I thought it might. But I do think that if you can take care of the increased cars and change the use of fuel by factories, a lot of this would be relatively easy to control. And the other thing about China is that I've seen them, you know, remember the Olympics. When the Chinese want to do something, they do it. I mean, they shut down, nobody's driving a car, and all of a sudden the air gets clean. So they really, if you do, we've seen this example very quickly in Beijing, where they limit the use of cars and the air pollution, it changes. Now, I think in India, it's tricky. I don't know about the religious holiday, I mean Diwali, and I don't know how important the burning is from a religious standpoint. So now it's a trickier discussion when you're talking about something that might affect a person's religion and how it relates to health, as opposed to changing the fuel that a factory is burning. But I think it's a discussion we need to have, because the quality of the air, we believe, is very important on our health. And as you point out, these gaseous emissions are also very important. And that's in the 2004 reference that I showed on the screen. The 2012 is microparticulate matter. The 2004 American Heart Statement goes into that in great detail. And I did read in the paper this morning that in Delhi, the discussion, they have like, it's a 46-point plan that's at least being discussed that gets into some kind of control on the fuel that plants are using, combustible energy in plants. So
thank you, Dr. Smith.
I think there's help or hope for this.
Thank you. Thank you for an excellent deliberation on a fascinating subject. Thank you very much.
Thank you for the excellent keynote addresses, and thanks to the chairpersons as well.